Welcome. In this explainer, we'll be covering the pathophysiology of tuberculosis. You're looking at the causative agent here, Mycobacterium tuberculosis. We're going to proceed through four main sections, starting with the etiology of the disease. From there, we'll discuss its transmission, then walk through the stages of a primary infection, and finally, we'll examine the various disease outcomes. So, let's begin with the etiology. It's important to understand that tuberculosis isn't just about the bacterium itself. It's intricately linked to various socioeconomic and host factors. Conditions like poverty, malnutrition, and living in overcrowded spaces create an environment where TB can thrive and where human defenses are weakened. This places certain populations at a significantly higher risk. For example, the elderly, incarcerated individuals, and critically, anyone who is immunocompromised. In fact, HIV is a major cofactor here, as it dramatically increases an individual's susceptibility to developing active TB.
Now, here is a crucial concept in tuberculosis. Infection does not equal active disease. Actually, only about 5 to 10% of individuals who are infected will go on to develop active, contagious tuberculosis in their lifetime. As this diagram illustrates, the infection typically begins with a primary lesion in the lung, which then involves the regional lymph nodes. And while tuberculosis is primarily a pulmonary disease, it has the potential for dissemination, meaning it can spread to other parts of the body, like the kidneys, the brain, or bone, which is known as extrapulmonary tuberculosis.
So, how is it transmitted? Well, tuberculosis is an airborne infection. When a person with active pulmonary TB coughs, sneezes, or even speaks, they expel infectious droplet nuclei. These droplets are incredibly small, allowing them to remain suspended in the air for several hours. When another person inhales these droplets, the bacilli travel all the way down into the deepest part of the lungs, the alveoli. And it's here, within the alveoli, that the bacteria begin to multiply.
Okay, once the bacteria are in the alveoli, the body's initial immune response begins. Alveolar macrophages, which are a type of immune cell, arrive and engulf the bacteria. However, M. tuberculosis has a very effective defense mechanism, its waxy cell wall. This wall protects the bacillus from being destroyed inside the macrophage, which allows it to survive and even replicate. Since the immune system can't eliminate the pathogen, it switches strategies. It walls off the infected macrophages, forming a small contained lesion known as a tubercle. This structure is the classic pathological hallmark of a tuberculosis infection.
Following that initial immune response, the infection can follow several distinct clinical pathways. We're now going to detail this entire process, looking at the full spectrum of possibilities. This includes the initial systemic infection and primary disease, the more severe outcomes like progressive or miliary disease, and finally, the potential for chronic or reactivation tuberculosis.
This flowchart is really key to understanding the potential fates of the infection. It all begins with the inhalation of infected droplets, leading to an initial, nonspecific bronchopneumonia. From here, there are a few possibilities. Complete resolution or, on the other extreme, massive necrosis are both quite rare. The most common pathway is progression. This triggers the cell-mediated immune response, leading to a positive tuberculin skin test and the development of resistance. Typically, this ends with the host successfully containing the bacilli within granulomas, resulting in a stable, latent infection. However, and this is a critical point, if the host's immunity wanes at any point in the future, that latent infection can become reactivated, causing active TB disease.
Let's focus now on the primary infection itself. In about 95% of cases, this begins as a single focus within the lungs. For the first 2 to 6 weeks, the bacteria multiply relatively unimpeded. During this period, though, the body is developing a powerful cell-mediated immune response, specifically a type 4 hypersensitivity reaction. Now, this response is a bit of a double-edged sword. On one hand, it's beneficial because it activates macrophages to kill the bacilli. But on the other hand, it also leads to tissue damage in the form of caseous necrosis, which creates that characteristic cheese-like necrotic core within the tubercle. A few months into the primary infection, a process called lymphohematogenous spread occurs. This is essentially a clinically silent phase where some bacteria escape from the primary lung lesion and disseminate throughout the body via the lymphatic system and the bloodstream. This body-wide seeding can deposit dormant bacilli in various distant organs, such as bones, kidneys, or the meninges. This is also the point at which an individual will convert to having a positive TB skin test. In a small number of children, this dissemination results in tiny calcified lesions in the apices of the lungs, which are known as Simon foci.
The infection can also have direct mechanical consequences on the airways. The regional lymph nodes are invariably involved. As these nodes become inflamed and enlarged, they can actually adhere to the wall of an adjacent bronchus. The infection may even erode through the node and ulcerate directly into the airway. When multiple enlarged nodes surround a bronchus, they can cause external compression. Later, as this inflammatory process heals with fibrosis, the scar tissue can lead to a permanent narrowing of the airway, a condition we call bronchial stenosis.
This diagram provides a clear visual of that exact process. You can see the green arrows indicating the infection spreading from the initial pulmonary focus into the adjacent lymph nodes. Those enlarged nodes then impinge upon and can ulcerate into the bronchial wall. The red arrow then points to the end result of this process after healing: fibrosis and a permanent bronchial stenosis, or narrowing.
Radiographically, a healed primary infection leaves behind some characteristic features. The most well-known is the Gone complex. This is composed of two parts: the original calcified peripheral lesion in the lung parenchyma and the calcified hilar lymph nodes that drain that area. You can also see the Simon foci at the apices of the lungs, those small scars left from the earlier hematogenous spread. And occasionally you might even find these tiny calcifications in other visceral sites, like the liver or spleen, which serves as evidence of how widely the infection disseminated.
This slide really brings the typical sequence together nicely. On the left, you see the initial infection, starting as a small focus in the lung periphery. The central image shows the next step, the spread to the regional lymph nodes. And finally, on the right, you see the most common outcome in an immunocompetent host, a healed primary infection, leaving behind those classic calcified signatures like the Gone complex and Simon foci.
But what happens if the immune system fails to contain the initial infection? In a small percentage of individuals, particularly young children and the immunocompromised, the primary infection progresses directly into active disease. This is called progressive primary disease. It can be quite destructive, leading to cavitation in the lung and spreading through the airways. The prognosis in these cases is serious. Without treatment, about 2/3 of these patients will succumb to the disease.
In this diagram illustrates the key features of progressive primary TB. You can see a large cavity in the upper lobe of the lung. This forms when the caseous necrotic center of a lesion liquefies and is coughed out. Also, note the extensive involvement of the lymph nodes in the center of the chest. And finally, you can see a pleural effusion, which is an accumulation of fluid in the space surrounding the lung caused by the inflammation spreading to the pleura.
Here we can see the mechanism of endobronchial spread. If a cavity or an infected lymph node erodes into an airway, it can discharge its infectious, caseous material directly into the bronchial tree. This material can then be aspirated into other parts of the lung, effectively seeding new areas of infection and causing a subsequent bronchopneumonia.
Now let's discuss a rare but very serious complication: miliary disease. This is a form of generalized hematogenous tuberculosis. It occurs when a caseous lesion ruptures directly into a blood vessel, releasing a massive number of bacilli into the bloodstream at once. These bacteria then disseminate throughout the body, forming innumerable tiny lesions that resemble millet seeds. This typically occurs within the first few months of the initial infection, and the prognosis is stark. If left untreated, miliary TB is uniformly fatal.
And finally, we come to chronic pulmonary TB, which is also known as reactivation or adult-type disease. This occurs only in individuals who have previously had a primary infection that became latent. Months or often many years later, if that person's immune system becomes compromised, the dormant bacilli, often located in the lung apices, can reactivate. The subsequent disease process is driven by a pronounced delayed-type hypersensitivity reaction. This intense immune response leads to significant tissue destruction and the formation of the classic pulmonary cavities. Though it may begin with minimal symptoms, this is the most common form of contagious TB in adults, and the dynamic between lifelong containment and potential reactivation represents the central challenge in the global control of tuberculosis.